Hello, doctors, please let me know. If you can hear my voice, please let me know. In the past, we've had issues with, our microphone and the rest. So please, if you are hearing me clearly, let me know. If there are any breaks as well, let me know so that we do it right before we start. Okay. The last time we had to stop in between and it wasn't good. Please, if you can hear me, just say yes, Dr. Bruni. It's clear. It's clear. It's clear. And please make sure that you send the link to as many friends as possible. I miss you guys. I miss you so much. I've been traveling a little bit, so I could not conduct the class, for the past 2 weeks. But I'm happy we are back. And in between, we provided you some very, very important content on our YouTube channel as well. I hope that content was helpful. Please let me know if that content was helpful. Just type yes, yes, yes. If you've not seen that content as well, I'll suggest going to our YouTube channel and then see. We talked about why candidates are not doing well. We also talked about how to use the MCC grid, okay, to ace your MedCognito exam. So please, if you don't know about it, I want you to know that we have all this on the YouTube channel. There's so much on the YouTube channel that you need to benefit from. So I will just share my screen quickly so that you know exactly what I talk about. We currently have more than 500 videos on the YouTube channel. So because people were asking me a lot about what to do and all those things, let me just share this with you. So please, if you've not been there, kindly go there. Oh, Dr. Sabine says we always miss your sessions, Dr. Bruni. Awesome. I'm back. Please send a link to as many friends as possible. Today we need to see about 200 people on this live call, okay? But I'm just sharing what I was talking about. So if you go to our YouTube page, let me see. Yeah, if you go to the MedCognito YouTube page like this, okay, there's so much. In fact, this is an interview with Dr. Alicia. She's from Barbados. She's currently practicing in Saskatchewan. How she went through her steps. And for those who want help with TDM, you can go listen to her as well. We have so much. And this is what I was talking about, okay? So if you, for example, you click on this, it's going to tell you, that MCC blueprint that we've been talking about. I've done a whole video on it as well. So many things on QE1 preparation. So iron deficiency anemia, why many candidates fail. I've done a whole video on it, breaking it down. What I also want to suggest is this. Some people have been sending me things they want me to address, how to maintain focus when they're preparing for the QE1 and all those things. If you have any of those, just send me a link or just send me a question. I will do my best to answer that question, not only for you, but for everybody, okay? And then how to even become a doctor in 2025, some of all the changes which are happening. So we'll be doing a lot of that content, but I want to develop this content with you. So if you have any question that you want me to address, just let me know. As I said, we have more than 532 videos on the YouTube channel. Just go there. So many things we've taught. Acid-base balance, that's also something a lot of people really enjoyed, okay? So if you have anything you want us to deal with, let us know. Just go through it. There's so much there for you. So let me not bore you with that, but just wanted you to know that there's a lot on the MedCognito YouTube channel that you can get so much from. All right? Okay. So now let's jump back to what we are to study today. So doctors, please click on the like and subscribe button on our YouTube. Share the link with as many friends as possible. Let them join and let's all study together. I know that the first batch of candidates who had to write the exam did it, and it was May 21st was the last day. So, people are relaxing a bit, but we also know people who are also taking the exam in August, September, right? So make sure that you get in, and those who are also preparing for the exam from 1st October to 22nd October as well. Very important, all right? So now let's jump into today's class. It's approach to COPD, but we're going to focus on, and NAC OSCE, sure. NAC OSCE is starting our class for NAC OSCE. I'll be talking about it, but it's starting on June 3rd. So currently we're even running an early bird promo, and we'll be very glad to help you with that, because from June 1st it goes back to the original price, but there's a 30% off. So if you are interested, just send me a message on +1 306 891 5649 +1 for those who want to write the NAC OSCE and want to take the course with us. Yes, Dr. Ronin. Yes, NAC OSCE starts on June 3rd. NAC OSCE classes, but the exam will be in September, right? So we're taking candidates for that. Okay, so let's get into the class, because today we have a lot to cover, and this class is going to cover both QE1 concepts and NAC OSCE concepts, because remember that the MCQE1 and the NAC OSCE follow the same objectives, right? They follow the same objectives. So let's go. So emergency approach to COPD. We're going to start with some questions, and then we'll take it from there. So doctors, please share the link with as many friends as possible, and then please go to our YouTube channel as well. Click on the like and subscribe button, and whenever we put any stuff out there, please make sure that you engage with the content as well, so that we can give you some reply. So let's review some questions. The first question says, which of the following is not one of the 3 cardinal symptoms used to define a COPD exacerbation? Which of the following is not one of the 3 cardinal symptoms used to define a COPD exacerbation? Okay, Dr. Ronin, I've gotten your WhatsApp message after the class. I think we can link up and finish everything up. So which of the following is not one of the 3 cardinal symptoms used to define a COPD exacerbation? A, increased cough frequency. B, chest pain. C, increased dyspnea. D, change in sputum character. And E, increased sputum volume. Let me know what your answers are. Which of the following is not one of the 3 cardinal symptoms used to define a COPD exacerbation? Used to define a COPD exacerbation. So the following is not one of the 3 cardinal symptoms. Okay. Dr. Imad, after the class, I'll get in touch with you as well. Okay. Thank you for reaching out. So yeah, I saw that initially people were going for E and D, but the correct answer is rather B. B is the correct answer, because chest pain is not a cardinal symptom of COPD exacerbation. Doctors, please. So from today, I thought this was going to be the easiest question. So from today, please remember, cough production, sputum production, dyspnea, these are all features of COPD exacerbation, okay? The one which is not a key feature of COPD exacerbation is chest pain. Chest pain. Chest pain is not a key feature. Okay, I'm going to the next question, and then after that, we'll delve deep. So please, let's focus, okay? Yep, a 71-year-old former smoker with stable COPD. She's suddenly short of breath with less activity and reports increasing cough for 6 days. His respiratory rate is 30 cycles per minute, and his SpO2 is 87% on room air. Which feature supports this being a true exacerbation, a true COPD exacerbation? A, he uses his rescue inhaler more frequently. B, his symptoms worsen gradually over 2 months. C, his symptoms symptoms are associated with thick purulent sputum. D, he had a recent spirometry showing FEV1 of 55%. And E, he has a productive cough every morning. Which feature supports this being a true COPD exacerbation? Which feature supports this being a true COPD exacerbation? Which feature supports this being a true COPD exacerbation? I'm getting B. I'm getting D. Okay, looks like that. Oh, I'm now getting A as well as one of the answers. So what's the correct answer here? The correct answer is C. 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 Definition of true COPD exacerbation. Now let's look at the ones other candidates went for. A, some says he's using his rescue inhaler more frequently. Well, some say B, his symptoms worsened gradually over 2 months. Let's jump from C and go to D. Some say that he had a recent spirometry showing FEV1 of 55. Well, that shows that the patient has COPD, but that doesn't show that the patient has a COPD exacerbation. E says he has a productive cough every morning. Well, does that mean there is exacerbation? So the true correct answer is C. Symptoms are associated with thick, purulent sputum. Now, why is C correct? C is correct because it's one of the key features of COPD exacerbation. That was what we were talking about, okay? One of the key features of COPD exacerbation is C. And if you want to find out the features of COPD exacerbation, there must be a change in the sputum character. There must be a change in the sputum quantity. Now, if you go to A, B, D, and E, you realize that B was testing you on the duration that you can talk about someone having COPD exacerbation. And this patient has had it for 6 days, but then B, the answer was talking about 2 months. In the class today, we are going to learn the right definition of, the timeline that you can say that somebody has a COPD exacerbation. Okay, all right. The next question: what is the most common cause of COPD exacerbation in clinical practice? What's the most common cause of COPD exacerbation in clinical practice? A, autoimmune lung inflammation. B, pulmonary fibrosis. C, viral or bacterial respiratory tract infection. D, drug-induced pulmonary toxicity. And E, thromboembolic disease. Which of the following is the most common cause? Remember, I'm asking the most common cause. The most common cause of COPD exacerbation in clinical practice. Is it A? Is it B? Is it C? Is it D? Or is it E? And it looks like this one, a lot of candidates are getting it right. And a lot of candidates are going for C, which is viral or bacterial respiratory tract infection. Okay, so C is correct, which is viral or respiratory tract infection. Respiratory infections are the leading trigger. Please, I need you to write this down. Respiratory infections are the leading trigger of COPD exacerbation. Doctors, while we are learning, don't forget to share and tell your friends to join this class right away. The MedCognito students as well, please get your candidates, your friends who you study with to join us so that we can all study together right away. Okay, viral and bacterial respiratory tract infection is the most common cause of acute COPD exacerbation and worsening. So doctors, did that help? Those sets of questions, did they help? Now let's do a deep dive into the introduction alone. Okay, so think about COPD exacerbation. Today we are focused on exacerbation as a flare-up. Okay, as a flare-up, because with patients with COPD, they are having cough, they are having sputum production, they are having, some have dyspnea. However, exacerbation is something which is worse than what was there initially. All right, and these patients, think about the COPD exacerbation as the patient's lung is already compromised, and then something is setting it off so that things worsen suddenly. That's what you want to think about. Okay, now what are the 3 cardinal signs and things you need to remember? Please, I need you to write this down in your book, and when you are done, kindly take a picture and send it to me on +1 306 891 5649. +1 306 891 5649. What are the 3 cardinal signs of COPD exacerbation? Number 1, there is worsening cough. Number 2, there is sputum production, which is happening more often, and that sputum is smelling different. Number 3, there is dyspnea. The patient is getting out of breath more easily than usual. Good. Dr. Rohin is sending me some pictures. Please also send me some pictures. Some are watching us by sitting by the window. Some are watching us with a bunch of food. It's nice. I really like it when I get those pictures, right? So what are the features of COPD exacerbation? There's cough, there's sputum production, there's dyspnea. These are the 3 main things that you need to remember. And remember that with the acronym CSD. CSD. Now, there are other signs of COPD exacerbation, There can be fast breathing. There can be fast heart rate, that is tachycardia. The patient may have low oxygen, that is hypoxemia. And all these things are happening because the patient has poor gas exchange. All right. Remember, the lung is compromised. So there's poor gas exchange. Now, these show that oxygen isn't getting to where the body needs it to get. Okay. The oxygen is not getting to where the body needs it to get. Now, what is the time frame for acute COPD exacerbation? Remember that one of the options we were learning in the class was talking about 2 months. But if you want to talk about acute COPD exacerbation, if you're talking about acute COPD exacerbation, then you are looking at worsening symptoms suddenly or over two week period. So it is 2 weeks or less. Okay, so 1 month, 2 months, no, that's not an acute COPD exacerbation. It is 2 weeks or less. 2 weeks or less. 2 weeks or less. That is when you say that the patient has COPD exacerbation. 2 weeks or less. Please write this as well in your book. 2 weeks or less. Now, what causes a flare-up? We learned in that question that the commonest cause of flare-ups is bacterial and viral infections. Bacterial and viral infections. But beyond the bacterial and viral infections, there are other causes of flare-ups. And one of them is air pollution, where there's, maybe there's smoke in the air or chemicals in the air or other chemical or airway irritants as well. These also lead to, exacerbations. But the commonest thing, remember the MCQ one, common things are common. Common things are always common. So the commonest cause of COPD flare-up, COPD exacerbation, is viral and bacterial infections. All right? Good. Now, because we're talking about COPD exacerbation in the MCQ1 and NAC OSCE, we're going to look at how to perform an initial assessment of a patient with acute COPD exacerbation. How to perform an initial assessment of a patient with acute COPD exacerbation. Let's go. Doctors, let's read this question together. So you have a 72-year-old man with a history of COPD, presents with a 5-day history of increased dyspnea and cough, but denies fever or sputum production. Oxygen saturation is 84% on room air. Despite bronchodilators, he remains tachypneic. What additional diagnosis should be considered in this patient? In other words, you have somebody who comes into the ER with COPD exacerbation. For example, the nursing team you are working with, oh, he's a frequent flyer. We know him. He always comes in with COPD exacerbation. Now today, you are giving your bronchodilators, you are giving your albuterol, you are even giving your short-acting muscarinic agonist. You are giving everything, but the patient seems not to be improving. What is that one diagnosis that you don't want to miss? Somebody has come in with COPD, symptoms of COPD exacerbation, but there is no fever, there's no sputum production, but this patient has dyspnea and cough. Please read it very well. For those who are typing the various answers, dyspnea and cough. So I have a question. I have a question for you. Dyspnea and cough. In bacterial pneumonia, there can be dyspnea, there can be cough. But are you expecting fever as well? In bacterial pneumonia, are you expecting sputum production? So if you went for A, think about it. B, in viral upper respiratory tract infection, can they have dyspnea? Can they have cough? What about fever and sputum production? This patient has dyspnea and cough, but does not have any fever, does not have any sputum production. So my question is this: in these patients, Dr. Fatima is getting it. Dr. Chidu is also getting it. Dr. Theodora is also getting it. Why am I saying that? Let's ask ourselves. In patients with bacterial pneumonia, they'll have fever, they'll have dyspnea, they'll have cough, they'll have sputum production, right? In patients with viral upper respiratory tract infection, they will have some fever as well. Let me jump C and go to D. In patients with COPD, if they are stable, they should not be having saturation of 84. In patients with bronchiectasis, they are really sick, right? So what one diagnosis should you not miss? Somebody comes in with shortness of breath. The patient just has dyspnea and cough, and there's no fever and there's no sputum production. Doctors, one diagnosis you don't want to miss is pulmonary embolism. Pulmonary embolism. Because in pulmonary embolism, you've got to always make sure that you're ruling out life-threatening stuff. Thank you, Dr. Farah. Right? You want to make sure that you're ruling out life-threatening stuff, life-threatening conditions. So somebody comes in, this is a regular flyer. He's coming with the regular COPD exacerbation, Dr. Bonnie. Let's just do the bronchodilators and give him some steroids. Okay. Let's give him some antibiotics as well. Okay. We've given antibiotics, nothing is helping. We've given him bronchodilators, nothing is helping. We've given him, steroids, nothing is helping. And then I'm still saying it's just COPD. Oh, forget it. It's just COPD. No. I need to start thinking about other things. What else could be going on? And one disease which can easily kill this patient that if I don't pay attention to may cause trouble is pulmonary embolism. Next question. A 68-year-old woman with COPD presents with new onset resting dyspnea, use of accessory muscles, and altered mental status. What's the most appropriate next step? 68-year-old woman, COPD, new onset of resting dyspnea, use of accessory muscles, and altered mental status. What's the most appropriate next step? A, start oral prednisone and discharge home. B, monitor her in the waiting room for 2 hours. C, admit to ICU for ventilatory support evaluation. D, send for outpatient pulmonary function testing. E, prescribe azithromycin and schedule a follow-up in 72 hours. Good. It looks like this one, we're getting it. A lot of doctors are going for C. A lot of doctors are going for C. Beautiful. So doctors are saying that we want to admit this patient to the ICU and we want to support them with ventilatory support. So admit to the ICU. This patient has life-threatening features and resting dyspnea, altered mental status, use of accessory muscles. If you start seeing these things, doctors, please, you should start thinking, this patient needs ICU. This patient needs ICU. If you have a patient with COPD and the patient is presenting with all these symptoms, please, one thing you need to know is that this patient may need ICU. ICU. In other words, death sees you, right? And that's why the patient needs to go to the ICU. Now, the differentials you need to know for COPD, I'm just going to hit on 4 of them. Heart failure, myocardial ischemia, that is like myocardial infarction and the rest, pneumonia, and pulmonary embolism. But in heart failure, how are you going to tell the difference between heart failure and COPD? You realize that in both COPD and heart failure, they may have shortness of breath, right? But in heart failure, they may also have pedal swelling or abdominal distension, or they may have soft tender hepatomegaly, or they may have some elevated jugular venous. When you look at the JVP, it may be elevated, right? And that's something which should draw your mind to it that maybe this is not just COPD. And don't forget that COPD itself, if poorly controlled, can also lead to right-sided heart failure, right? Number 2, myocardial ischemia. Patients with myocardial ischemia can also have breathlessness and fatigue, especially if it's a silent myocardial ischemia, right? And then pneumonia. But most of the time, you realize that with pneumonia, they may have some fever, they may have some sputum production, and so it may overlap. But don't forget that you're going to give your antibiotics in pneumonia and in COPD exacerbation as well. In some circumstances, you give your antibiotics, right? But then it's the pulmonary embolism bit that I want to focus on. Okay? In pulmonary embolism, I want you to focus on that. There is sudden onset of symptoms. Most of the time, the patient does not present with fever. Most of the time, the patient does not present with sputum production. And they are requiring a lot of oxygen with no clear reason. It should start telling you that, no, something is going on here. So how do I differentiate COPD exacerbation from pure heart failure? You realize that, yes, both of them will have shortness of breath, but in heart failure, there may be pedal swelling, right? Myocardial ischemia, I may see some changes on ECG. Pulmonary embolism. I've given all my COPD treatments. This patient does not have fever. This patient does not have sputum production, but the patient's oxygen saturation is not improving. It should tell me that there's a problem. Okay, good. Next question. Which of the following is not an appropriate reason for hospitalization in COPD? Which of the following is not an appropriate reason for hospitalization in COPD exacerbation? A, severe airflow limitation on spirometry 3 months ago. B, need for high FiO2 to maintain oxygen saturation. C, mild symptom increase with good home support. D, new peripheral edema in a patient with cardiac history. And E, inadequate response to ER bronchodilator therapy. Remember, we are dealing with COPD exacerbation. Doctors, click on the like and subscribe button and help us to grow the YouTube channel as well, so we can get it to as many candidates as possible. Because I get a lot of calls. Oh, Dr. Bruni, I saw MedCognito because, you know, I saw you on YouTube, and I'm going like, oh, that's nice. You know, that's nice to hear. So doctors, please click on the like and subscribe button, and then let's help to grow the channel together. So far, we are at 2,532 subscribers. Let's hit 2,550 subscribers by the end of this class today. 2,550, okay, subscribers by the end of this class. So if you're not subscribed to the YouTube channel, please go there and subscribe right away, okay? We have quite a number of doctors on the live class today, so that's beautiful. Okay, so which of the following is not an appropriate reason for hospitalization? A, severe airflow limitation on spirometry 3 months ago. B, need for high FiO2 to maintain oxygen saturation. C, mild symptom increase with good home support. D, new peripheral edema in a patient with cardiac history. And E, inadequate response to ER bronchodilator therapy. What's the correct answer? The correct answer here is C. Mild symptom increase with good home support. If you have a patient like that, you want that patient to go home, right? That patient can go home. You don't need to keep the patient in the hospital. Okay, you can manage the patient appropriately on outpatient basis. Next question. So a patient with COPD exacerbation responds well to bronchodilator and steroid therapy in the ER. Vitals stabilize, oxygenation improves, and they are alert. What next step is most appropriate? What's the next best step? So this like a next best step concept, right? What's the next best step? A, admit to the hospital for observation. B, refer to ICU for ventilation. C, discharge with close follow-up and home support. D, schedule pulmonary rehab before discharge. And E, perform chest CT to rule out malignancy. Perform chest CT to rule out malignancy. Doctors, let's click on the like and subscribe button. Let's smash it, smash it, smash it, smash it, smash it. We are doing this for you. So click on the like and subscribe button. Let's smash it, okay? Good. So for this one, it looks like this is also pretty straightforward. A lot of doctors are going for C, discharge with close follow-up and home support. Because, you know, with a favorable ER response, that's what you want to do for this particular patient, right? Now, I want us to focus on who to send home and who to hospitalize for a COPD exacerbation. Don't forget that the essence of the QE1 is, how is Dr. Farhan Khan, Dr. Benis Bimpong, Dr. Ajiboye, Dr. Aizat Nouri, how are these doctors who are taking the exam, how are they going to keep the Canadians safe and alive if they should come to them in the emergency room? That's all that the medical council is thinking about. How do you keep people safe and alive? Okay, so we've got to know, who are we going to send home, who are we going to hospitalize so far as COPD exacerbation is concerned. Doctors, I have a question, please. So far, is the class helping? Is the class helpful? Is it opening up things we're not paying attention to? I want to know. Just give me that feedback, yes or no. Is the class helping? Is it helpful? Because maybe had you looked at COPD exacerbation in this context before? Is the class helping and is it helpful? Okay, good. That's great. That's great. That's great. Okay, good. So who are we going to send home and who are we going to hospitalize? First, who to send home after a COPD exacerbation. It's not everybody who has a COPD exacerbation that you admit, right? Who are you going to send home? Number one, if the patient has mild symptoms, I need you to write this down. Dr. Sabine, Dr. Fatima, Dr. Bennett, Dr. Melanie, Dr. Druvi, write it down. Dr. Farah Khan, who am I going to send home after a COPD exacerbation? Number one, mild symptoms. Number two, no red flags. Number three, if the patient has good home support, I'm going to send home. Number four, if the patient understands follow-up instructions, I'm going to send home. Okay, who am I going to send home? Mild symptoms, no red flags, good home support, and understands follow-up instructions. And doctors, please, I need you to note this. After this class, I'm going to do an active recall lesson on what we just did. So I'm going to also give you questions where I'm not providing you answers, and this time you need to provide the answers. So if you are listening to this class lying in bed, no, you need to sit up and take notes, because the last part of this class, as I told you the last time, is that I'm introducing active recall, okay, so that when I teach something, you can also recall the lessons and tell me what exactly I taught. Because when I provide you with MCQ options, yeah, you can easily choose, and the exam has moved there. But the person who can really ace an MCQ question is one who can also actively recall what has been taught in class. So part of this is, if you are just lying in bed and watching passively or something, no. After the class, we are going to do an active recall lesson on this. All right, thank you very much. Thank you for the word so sweet. Okay, good. So who am I going to admit? Who am I going to admit? If the person has respiratory distress, like using accessory muscles of respiration, cyanosis, paradoxical breathing, I'm going to admit that patient. If there are emergency signs, for example, the patient is hemodynamically unstable, if I see that in my MCQ1 preparation or in my board exam, I'm going to admit that patient. If I have a COPD who has altered mental status, I'm going to admit that patient, right? If I have a patient who does not improve after emergency room or clinic treatment, I'm going to admit that patient. If that patient tried outpatient care and has been having frequent exacerbations, I'm going to admit that patient as well. Okay, if that patient also has some life-threatening features like acidosis, and someone goes like, oh, acidosis. Many people contacted me saying that, Dr. Bruni, that acid-base class you taught was awesome. So doctors, please, if acid-base is a problem, okay, we did a whole, I don't know how many hours that class was, but I'm just going to check it, and I'm going to put the link in the comment section. For those who are in that class, they really enjoyed it, but I'm going to put a link in our comment section right now, okay? Because I just talked about acid-based stuff, and someone is saying, Dr. Bruni, that is my weakness. Somebody just sent me a private message right now, so I'm going to share the link to the acid-based class, okay? Just the acid-based class, yeah. It was done a couple of months ago. It was done just 1 month ago, yeah. So please, doctors, if you have a problem with that, this was a very, very well attended class. Okay, I've sent it. So if you're watching us on YouTube, you will see it. If you're also watching us on Facebook, you will see it. Just click on the link, and yeah, okay, Dr. Obina says it was done in April. Doctors, please, I've shared the link to the acid-based class, okay? Just click on it. It will take you there. When this class is done, go there and review your concepts on acid-based issues. So we are looking at who to admit, and we just got to life-threatening features like acidosis, hypercapnia, okay? And then arrhythmias or cardiac issues. So if you have a patient who has COPD exacerbation and also has arrhythmias or cardiac problems, you want to admit that patient. If the patient is a geriatric patient who is also very frail, cannot cope at home alone, you want to admit that patient. And if the support at home is inadequate, please do your best to support, to admit that patient. All right, doctor, so please, is it clear? Those to admit and those to send home. Those to admit and those to send home. Dr. Farhan Khan says that was an awesome, even last year, acid base was too good too. But this year we added more stuff, right? And then Dr. Asma says it was wonderful. And Dr. Ronin says, I like the red flags. I like the red flags. So please remember, that's an acronym on its own. Who to admit? Red flags, respiratory distress, emergency signs, doesn't improve after ER or clinic treatment, failed outpatient care, or has frequent past exacerbations, life-threatening features, arrhythmias or cardiac issues, geriatric frailty, and then support at home is inadequate. You want to admit that patient. Now, another place that a lot of candidates worry so much about is next best step concepts. Next best step. Patient comes in with what's the next best step? And then candidates are torn. Do I do investigation? Do I admit? What do I do? So I'm also going to quiz you on next best step situations in acute COPD exacerbation. Doctors, please, are you ready to go? Are you ready to go? If you are ready, type yes, yes, yes. I'm ready to go. If you are ready, just type yes, yes, yes. I'm ready to go. And we'll get a ball rolling. If you are ready to go, let me know. If you're ready to go. Think I need to make sure that this is also shared in our Facebook group. So doctors, if you're not in our Facebook group, kindly make sure you are there, because I'm sharing this as well right now. Okay, I'm sharing this in our free Facebook group. I'm sharing this in our free Facebook group, and then we'll move on to the next best step questions, how to deal with them. How to deal with them. Just pardon me. I'm sharing this link in the Facebook group as well. So approach to COPD exacerbation. All right. So for those in the Facebook group as well, you can also get the best out of it. And if you're not in our Facebook group, I'm going to put the link as well in the comment section. You can join it right away. And that's also a place we support a lot of our candidates as well. It has more than 3,000 doctors there. You can form study groups with friends, and all that. Okay, so now let's look at the next best step situations. Let's go to the next best step situations. Dr. Maria, thank you. So Dr. Maria says, thank you for this class. It helps a lot. Sure. Dr. Maria, that's what we do here, right? We want to make sure we help as many people as possible. Okay, so next best step. Let's try some questions. 68-year-old woman with COPD presents to the emergency department with a 2-day history of increased dyspnea. On exam, she's confused, she's tachypneic, using accessory muscles to breathe. Her oxygen saturation is 86 on high flow nasal cannula. She has a history of chronic hypercapnia. Which of the following is the most appropriate next step? Boom. Which of the following is the most appropriate next step? A. Start oral corticosteroids and monitor at home. B. Initiate non-invasive ventilation and observe in the outpatient clinic. C. Perform ABG and wait for results before deciding on management. D. Admit to ICU and initiate non-invasive ventilation. And E. Admit to ICU and perform endotracheal intubation immediately. 68-year-old woman, 2-day history, increased dyspnea, confusion, tachypnea, accessory muscles to breathe, right? Oxygen is 86, chronic hypercapnia. What will you do? So I see D, I see D, I see E as well. And then I see D, and I see E, and I see D. And so D, E, C, D, E, D, E, C. Okay, so now what will I do? This one, I'm going to admit the patient to the ICU and initiate non-invasive ventilation. This patient has dyspnea. This patient has red flags. Okay, so this patient needs to be admitted. Now, where should I admit the patient? The patient's SpO2 is less than 88%. The patient is confused. The patient is using accessory muscles of respiration and has hypercapnia. You realize that this patient does not meet the criteria for immediate intubation. And we'll be learning that as well. The criteria for immediate intubation in a patient with COPD. Because this patient does not have any airway loss, no agonal breathing, and is not in cardiac arrest. So there's no need to intubate the patient, but this patient needs to go to the ICU. ICU means that says I see you. Therefore, you don't want to let the patient go home. I see you, right? So you don't want the patient to go home. You want the patient to be admitted and managed properly. ICU. But even though the patient is going to the ICU, do you put, a scope there and then put a tube? No. You rather do your non-invasive ventilation. Okay. So non-invasive ventilation is the first step under ICU monitoring. But when will I intubate a patient with COPD exacerbation? If the patient develops cardiac arrest, please write it down. If the patient has airway loss, like that is respiratory failure, or if the patient is in agonal breathing, then I want to intubate that patient. Next question. You have a 72-year-old man with a COPD exacerbation, presents with respiratory distress. He's lethargic. His GCS score is 10/15. He's vomiting large amounts of gastric contents. His ABG is 7.29. Wow. This patient is obviously acidotic. And the PaCO2 is 58. Which of the following is the most appropriate next step? Most appropriate next step. Patient is GCS 10. So that means the patient is right? GCS is 10. The patient's GCS is low. The patient is vomiting. The patient is lethargic. And the patient is producing a lot of gastric content. What will you do? A. Initiate non-invasive ventilation in the emergency room. B. Admit to the ward to continue oxygen therapy. C. Begin high-dose oral steroids. And I see somebody, Dr. Ronin is writing something here. Let me just read it. It says, definitely not C. Why? Because this patient is vomiting, right? And the patient is unconscious. So how can the patient who is unconscious even swallow the pill you are giving? So that's a good exam taking technique. D. Emergent intubation and mechanical ventilation. And E. Observe in the emergency department with repeat ABGs in 2 hours. What will you do? The patient's GCS is 10. So the patient's GCS is low. What will you do, doctors? What will you do? And I see a lot of doctors are going for D. And that's the correct one. Emergent intubation and mechanical ventilation. That's exactly what you want to do. You realize that, so now that we are learning this in COPD exacerbation management, we learned indications for intubation. Please, before we move on, who can remind me of the indications for intubation? Please, who can remind me? Just type the answers. Who can remind me of the indications for intubation? Indications for intubation. Indications for intubation in a patient with COPD exacerbation. What are the indications for intubation? And then we also have to look at indications for non-invasive ventilation. Beautiful. Cardiac arrest. What else? We said agonal breathing and respiratory collapse, right? Now, this patient, can we just say we're going to give NIV, we're going to do our non-invasive ventilation? This patient is vomiting, right? So, non-invasive ventilation as well is contraindicated in the patient who is lethargic, who is vomiting, and who has a low Glasgow coma scale. The reason is because a patient like that has a risk of respiratory, failure, and also they cannot protect their airway. So you don't want to do non-invasive ventilation. Therefore, in this patient, we're going to do intubation. So please, doctors, write down your indications for intubation in a patient with COPD exacerbation, and then contraindications for non-invasive ventilation. I've just taken you through that. But please write it down, take a picture, send it to me by WhatsApp right away. Take a picture, send it to me on 306-891-5649. 306-891-5649. Indications for intubation in a patient with COPD, contraindications for non-invasive therapy. Okay, so let's go to the next question. You see why I like to teach with questions? Because it helps to broaden the conversation. It's not just like we are going through something, it helps to broaden the conversation, right? So a 65-year-old woman with COPD exacerbation is started on non-invasive ventilation in the ICU. After 2 hours, she remains tachypneic with respiratory rate of 35 cycles per minute. Her SpO2 is 86% on BiPAP, and a repeat ABG is 7.23. So this patient is acidotic. What's the next best step? A, continue NIV and reassess in 4 hours. B, administer bronchodilators and observe. C, switching to high flow nasal cannula oxygen. D, discontinue NIV and initiate invasive mechanical ventilation. And E, discharge home with oral prednisone. While you're going on, someone just asked the question, sir, please, what's the cutoff for GCS? Now, usually the teaching is that indications for intubation is a GCS of less than 8. Usually the teaching is that. But you realize that that patient we dealt with, this patient is already obtunded. This patient has other things which will not help if you are just focusing on the Glasgow Coma Scale score alone. Okay, Dr. Noel. So that's why, despite the fact that that patient's GCS was 10, we still wanted to intubate the patient. Right? Good. Okay. So what will we do for this patient? I can see what is happening. It looks like the non-invasive ventilation is not working. And so a lot of doctors are going for D. They said that we should discontinue the non-invasive ventilation and initiate invasive mechanical ventilation. Non-invasive ventilation has failed. The patient is having persistent hypoxemia. The patient has an SpO2 which is less than 88, and there's worsening respiratory acidosis. So this patient needs to go beyond non-invasive ventilation and go for intubation. Next question. A 74-year-old man with COPD presents with moderate dyspnea. He has no signs of respiratory acidosis, and oxygen saturation is 93% on room air. Chest X-ray shows right lower lobe pneumonia. He has a new peripheral edema and irregular heartbeats. What's the next best disposition plan? Remember, doctors, that was what I was talking about. Next best step, next best step, next best step. Candidates struggle with that. That's why I'm trying to infuse that into the teaching. Okay, so discharge with oral antibiotics and arrange a home care. B, admit to ICU for ventilatory support. C, admit to ICU due to non-respiratory complications. D, observe in emergency for 24 hours, then reassess. E, schedule urgent outpatient cardiology follow-up. SpO2 is 93% on room air. Chest X-ray shows pneumonia, peripheral edema, irregular heart rate or heartbeat. What will you do? So I see that some are going for B, some are also going for C, and some are going for observing in the emergency department for 24 hours and reassessing. What will you do? From the COPD perspective, this patient is okay. From the COPD perspective, oxygen saturation is 93, the patient is stable, right? But then it looks like the patient has some cardiac issues going on. Irregular heart rate, peripheral edema, and right lower lobe pneumonia. The patient may be stable right now, but if I should let the patient go home, something may happen. So this patient may be, at this time, may not need ventilatory support per se, but this patient needs to be in a place where the patient can be observed more and can be observed better, right? So that is something you want to pay attention to. So the correct answer is C, admit to the ICU due to non-respiratory complications, the arrhythmia, right? He doesn't need ventilation, but he has other ICU indicators. So we will also learn about the indications for ICU, okay? New pneumonia, edema, and arrhythmia. And remember, we're talking about it. A patient with shortness of breath with edema. When we're talking about the 4 top differentials, we have to remember. I want to know who remembers that. The 4 top differentials of COPD exacerbation that we need to remember. The 4 top differentials of COPD exacerbation that we need to remember. Who remembers it, please? Who remembers that? Who remembers that? The 4 top differentials of COPD exacerbation that we need to remember. Who remembers it, please? Who remembers it? Heart failure, good. Cardiac ischemia, what else? 2 more. heart failure, PE, pulmonary embolism, beautiful. That's Dr. Olusegun said myocardial infarction. And then what else? So Dr. Mehu said the 4 top differentials are pulmonary embolism, pneumonia, congestive heart failure, and myocardial infarction. Beautiful. Those 4 top differentials. Top differentials. So we said that what separates heart failure from the rest is, yes, the patient may have cough, shortness of breath. These are all features of heart failure. But then what sets it apart from regular COPD is that you may see signs of edema. And then we also said that what sets pulmonary embolism from regular COPD exacerbation is that in pulmonary embolism, the patient may have the cough like COPD, you may have the shortness of breath like the COPD, but you're giving the oxygen, the patient is not improving. You're giving the steroids, the patient is not improving. You're giving the antibiotics, the patient is not improving. You're giving your perfect, the patient is not improving. It should cause you to say, there's a problem, right? So in the MCQ1, these are the things you want to start paying attention to. These are the things you want to start paying attention to in the MCQ1. These are the things you want to start paying attention to, doctors. Please. So you realize that I always say, look, this exam is not just an issue of I've read this book and I've read that book. It's about the patient who has been given to you. How are you going to manage that particular unique patient? Right? Okay, good. So, next question. You have a 62-year-old patient with COPD, comes to the clinic for increased cough and sputum production. His vital signs are respiratory rate of 22 cycles per minute, heart rate of 92 beats per minute, SpO2 of 95% on room air. Mental status is normal. After 2 bronchodilator treatments, the patient says they feel much better and can walk around. He lives with his daughter who can assist, right? So that tells you that the patient has good home support. What's the most appropriate next step? A, admit to the ICU for monitoring. B, admit to the hospital ward. C, discharge with close outpatient follow-up. D, perform urgent chest CT scan. And E, start oral steroids and observe in the emergency department for 24 hours. What will you do? So I see a lot of us. The patient seems to have improved. The patient has good home support. Oxygen saturation is good. Okay, so you want to discharge with close outpatient follow-up. That's the correct answer. Beautiful, beautiful, beautiful. So this patient has mild symptoms, good response to treatment, and home support. And therefore, that patient is suitable for outpatient management. Suitable for outpatient management. Doctors, most of the time after this class, after these classes, I get a lot of messages, right? So what I'll suggest is, if you want to speak to me, send a WhatsApp right now, so that after that, I'll just follow in that order. If you want to speak to me, just send a WhatsApp right now after this class. +1 306 891 5649. +1 306 891 5649. And we'll get talking. Dr. Obina Victor says, no red flag. Beautiful. Therefore, this patient can go home. Okay. So now, doctors, I have a question. Did the next best step situations we've gone through, did they help? Did they help at all? Did they help? They helped. Let me know. Did they help? Good. So now let's do a deep dive into the next best step situation. Let's do a deep dive into the next best step situation in COPD. Okay, how to master that. Number 1, if you have presented with a case of COPD in your board exam, first question you have to ask yourself, this patient, does the patient need emergency intubation? Can we try non-invasive ventilation like BiPAP? Can the patient stay out of the ICU and go home or to the ward? Right? These are the questions you want to ask yourself. These are the questions you want to ask yourself in every MCQ1 board exam about COPD. Okay? Now, in a patient with acute COPD exacerbation, you want to ask yourself, does this patient need to be intubated? So, let's take our time and look into it. Who to be intubated right away in acute COPD exacerbation? Please, I need you to write this down in your books. I need to write it down, take a picture, send to me. What are the indications for intubation? Number 1, a patient with acute cardiopulmonary arrest. What are the indications for intubation right away in a patient with acute COPD exacerbation? Cardiopulmonary arrest. Number 2, if the patient is hemodynamically unstable and you've tried everything, you've given your fluids, you've given your pressors, the patient is still not responding, the patient needs to be intubated. Number 3, if the patient cannot protect their airway, the patient is becoming drowsy and the patient is vomiting, and there's the likelihood that this patient can aspirate. So can you imagine a patient with COPD already, and then the patient aspirating and developing aspiration pneumonia? Oh my goodness, that would be crazy, right? Number 4, agonal breathing. Please write this down. Send me a picture. What are the indications for intubation in a patient with COPD exacerbation? Cardiopulmonary arrest, hemodynamic instability, inability for the patient to protect their airway, and a patient with agonal breathing. If in your board exam you see any of these as one of the question stems or anything, please choose intubation. Please, if in your board exam you see any of these as one of the parts in the question stem, choose intubation. However, if the patient does not need intubation, like putting this tube and putting the laryngoscope down, then you go to step 2. The patient does not have agonal breathing. The patient is not in cardiopulmonary arrest. The patient is not vomiting. The patient can protect their airway, right? But then, in your board exam situation, you realize that this patient's SpO2 is less than 88%, despite you giving oxygen. The patient is using extra muscles to breathe, and the chest is moving in the wrong way. That is paradoxical breathing. The patient is getting confused or sleepy, and the patient has a history of high CO2 or hypercapnia. In those patients, you want to consider ICU and try non-invasive ventilation. But you want to keep it in mind that if non-invasive ventilation does not work, I'm going to go ahead and intubate my patient, right? So please, we've learned the indications for intubation. We are now learning the indications for ICU admission and non-invasive ventilation. If non-invasive ventilation fails, what should you do? Please type it in the comment section. If non-invasive ventilation fails, what should you do? I want to know. We've tried non-invasive ventilation. If it fails, what should you do? Please, doctors, type the answer before I move on. If non-invasive ventilation fails, what should I do? Good. So I've seen the answer. Intubate. Intubate the patient. Intubate the patient. Doctors, you see, Q1 is all about a stepwise approach. It's not just about learning a bunch of information. No, it's a stepwise approach. Stepwise approach. Okay. Now, if the patient cannot tolerate non-invasive ventilation and not improving on non-invasive ventilation or has contraindications to non-invasive ventilation, then doctors intubate. Okay, let me say it again. If the patient cannot tolerate non-invasive ventilation, or the patient is not improving on non-invasive ventilation, or the patient has contraindications to non-invasive ventilation, then doctors go ahead and intubate. You have to choose intubation as your answer. So what are the contraindications to non-invasive ventilation? Say that if the patient has any of these, then you are going to go ahead and intubate. Number 1, inability to protect the airway or clear secretions. Intubate the patient. Severely impaired consciousness. You can't do non-invasive ventilation in that patient. Therefore, that patient needs to be intubated. Non-respiratory organ failure. That is acutely life-threatening. Please go on and intubate the patient. If the patient has a high risk of aspiration, please go ahead, put a tube. If the patient has had facial surgery, trauma, or facial deformity, please intubate. And if there's recent esophageal anastomosis, please intubate. So we've looked at the indications for intubation. We've looked at the indications for non-invasive ventilation in a patient with COPD, and we are looking at the contraindications to non-invasive ventilation. Doc, please, how is it? How is it going? QE1, NAC OSCE made ridiculously simple by MedCognito. That's what we do here, right? Okay, good. So now, let's go back. Let's go back. Now, the patient did not need intubation. You tried your non-invasive ventilation. What do? Another thing, you want to check your arterial blood gases. And as I said, we've done a whole class on acid-base balance. If you want to revise that, I know it is a weakness for many candidates, right? Because many candidates have reached out. If you want to revise that, I'm going to put the link in the comment section again. Because you see, when it comes to COPD, acid-base balance keeps coming up. Acid-base balance keeps coming up. It keeps coming up. So I'm going to share the link again in the comment section, so that if it is something you struggle with, please make sure that you are able to look at it. Okay. Oh, Dr. Bennett says learning with you is awesome. That's good. Thank you, doctor. Thank you. We put a lot of effort into, making sure that we give you good stuff so you can use it to prepare for your exam. Okay. So if the patient is in acidosis, like the pH is less than 7.35, and if you watch the acid-base class, you realize what we're talking about. Or if the PaCO2 is more than 45, then you want to try your non-invasive ventilation. But first, you want to check, step 4. Can they even use non-invasive ventilation at all? Right? We've looked at the indications and the contraindications. So now, if no, then you want to go to step 5. So, is non-invasive ventilation safe for this patient? That's the question you have to ask yourself in the MCQ, right? If they can't stay awake, if they are vomiting, if they have head or facial trauma, then if any of these is there, then don't try a non-invasive ventilation. Go ahead and do your intubation. Okay? Good. But what about if the patient is not that sick, but still needs hospital? Even if they don't need the intubation or the ventilator, they may need hospital admission or ICU admission. Okay, so who needs hospital or ICU admission even though they don't need intubation? If the patient is not getting better with ER treatment, if there's heart failure or kidney or liver failure, if there's pneumonia on imaging, okay, remember that we talked about that. If there's confusion, if there's arrhythmia, so the patient may be good from a COPD perspective, right? In your board exam, the patient may be good from a COPD perspective. Oxygen saturation is now around 95%, but then the patient has an arrhythmia. You can't send that patient home. You've got to still keep the patient in the hospital, or even better still, in the ICU, and do some further treatment for the patient. If the patient is frail or no one is at home to help, admit the patient to the ICU. Okay, good. So let's just do a summary of everything we just did in a table form. Is your patient crashing hemodynamically, mental-wise? That one, intubate the patient and admit to the ICU. Is the patient having agonal breathing? Admit to the ICU. Right? Is the patient having cardiopulmonary arrest? Admit to the ICU. Okay, what about if the patient has severe breathing problems or the arterial blood gas is showing acidosis, but the patient's condition is not that bad, which needs intubation? Then try your non-invasive ventilation. But what if the patient qualifies for non-invasive ventilation, but the patient has some other contraindications like facial trauma, like excessive vomiting, like the patient cannot be very conscious? Then remember, you want to intubate. What if the patient is not improving or has a serious comorbidity but does not qualify for intubation? Then you want to admit to the hospital or the ICU. What if the patient is breathing better and the patient has good support at home? Then you want to send the patient home for outpatient follow-up. Doctors, this is it. This is the table. This helps you to put everything into perspective. So with all that I went through, indications for intubation, agonal breathing, cardiopulmonary arrest, respiratory failure. Okay, intubate. Okay, what about if the patient does not qualify for that but can try some non-invasive ventilation? But I have to know my contraindications for non-invasive ventilation. Vomiting, facial trauma, the patient cannot protect the airway, right? Then I want to intubate. But what if the patient is good from a COPD perspective, but then may have some arrhythmias or has new onset pneumonia or something? Then I want to admit the patient to either the general ward or the ICU, depending on the severity. But the patient can eat, the patient can breathe better, the patient has family members who can help him, the patient understands when to come and seek for help. Come on, let the patient go home. All right, let the patient go home. Okay, so if the patient can't breathe, can't think, or can't improve, send the patient to the ICU. That is the sample I want to put there. If the patient can't breathe, can't think, as in like mental status is worsening, or can't improve, please send the patient to the ICU. Doctors, please, did it help? I want to ask, did it help? Did this help? Remember, we are now going to go to the outpatient management, and we'll go to even deep ICU management for a patient with COPD for the QE1, and then we'll do our active recall. So we still have a lot to do. Please don't forget, tell your friends to join us. Don't forget, tell your friends to join us. Okay? So a lot of doctors are saying, yes, it helped, it helped, it helped, it helped, it helped. Awesome, 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 awesome. Okay. Now let's get to outpatient COPD management. Let's try some questions. A 73-year-old woman presents to the clinic with COPD exacerbation. She has the following: dyspnea score of 6/10 with clear sputum, respiratory rate of 26 cycles per minute, heart rate is 100 beats per minute, SpO2 is 91% on 2 liters of nasal cannula, CRP is slightly elevated, 12. Let me see. I have to check the CRP levels. Which of the following is the best next step? You are the best. Oh, that asthma says you are the best. Oh, so which of the following is the best next step? A, start oral prednisone 40 milligrams daily for 5 days. B, prescribe azithromycin 5-day course. C, start inhaled budesonide formoterol only. D, monitor without pharmacological intervention. And E, send the patient for hospital admission. What will you do? What will you do? 73-year-old woman in the clinic, COPD exacerbation, dyspnea 6/10, heart rate, respiratory rate 26, but the patient does not have any like change in the color of the sputum, right? Heart rate is 100, SpO2 is 91% on 2 liters, and CRP is 12. Dr. Ronin says clear sputum, hey? Okay, good. It was put there intentionally. We don't put anything anyhow, right? So what will you do? What's the correct answer? Are you going to give a steroid? And the correct answer is A, start oral prednisone 40 milligrams every day for 5 days. Okay? Because that is what is aligned with the guidelines. So why didn't we give antibiotics? Who can help me? Why didn't we give antibiotics? Because we have to understand the indication for antibiotics in outpatient management. Remember, you're writing a board exam, okay? Why did we? Beautiful. Dr. Sabine says we didn't give the antibiotics because of clear sputum. Okay, so now next question. 65-year-old man with COPD presents to your clinic with worsening cough and increased sputum. He denies fever but notes the sputum is now thicker and yellow-green. No changes in oxygen saturation or requirement. Which of the following findings would best support antibiotic therapy? A, use of accessory muscles. B, elevated CRP. C, increased sputum prurience and volume. D, dyspnea score of 3/10. And E, history of eosinophilia during prior exacerbations. Which of the following findings would best support antibiotic therapy? And the correct answer is C, increased sputum prurience and volume. So, what is the indication for antibiotic? I need you to write this down. Please write it down. Write this down. What's the indication for antibiotic therapy in a patient with COPD? Exacerbation. If there's more than or equal to 2 of the 3 cardinal symptoms of COPD. So, if the patient has 2 or all 3, you want to give antibiotics. Dyspnea, sputum volume has increased, sputum prurience has worsened. These are the 3 indications for antibiotics in a patient with COPD exacerbation. The patient's dyspnea is worsening. If the sputum volume is getting worse, if the sputum prurience is getting worse, you want to give your antibiotics. Okay, good. Next question. A 70-year-old woman with moderate COPD exacerbation is prescribed albuterol MDI every 2 hours, but reports difficulty coordinating inhalation and timing. She asks if she can use a nebulizer instead. What's the most accurate statement? A, nebulized therapy is preferred over metered dose inhaler for all patients, that's MDI. B, nebulizers provide stronger bronchodilation than metered dose inhalers. C, properly used metered dose inhaler is as effective as nebulized therapy. D, nebulizers should only be used in emergency settings. And E, MDI cannot be used more than 3 times a day. This is telling me something. I'm seeing the answers. Some are going for D. Nebulizers should only be used in emergency settings. Doctors, do you know that in Canada we have patients who have nebulizers at home and they can use it whenever they don't need to be in the emergency room to use a nebulizer. Okay, I'm just throwing that out there. So what's the correct answer? The correct answer should be C. Properly used metered dose inhalers is as effective as nebulized therapy. Properly used metered dose inhaler is as effective as nebulized therapy. What do I mean by that? Studies show that there's equivalent effect when metered dose inhaler is used properly. Very similar effects, right? Because I remember during the COVID-19 pandemic, right? During the COVID-19 pandemic, when there was a lot of how is this virus moving and everything, and aerosolized procedures were reduced, we're doing a lot of metered dose inhaler management for our patients, right? And realized that we're getting the same results. Good. So Dr. Mehu wrote an equation here. He says this: MDI is equal to nebulizer if used properly. Okay, if used properly. Okay, good. So now let's do a deep dive into the outpatient management of COPD. First step, you have to determine the severity of COPD exacerbation. You want to use your vital signs, you want to use your dyspnea level, and you want to use your SpO2 to guide you. Okay, so we have the room criteria. The room criteria for moderate exacerbation, if the patient has more than or equal to 3 of the following. So number 1, if the patient's dyspnea score is more than or equal to 5/10, if their respiratory rate is more than or equal to 24, if their heart rate is more than or equal to 95, if their SpO2 is less than 92% on the baseline oxygen, okay, and if their CRP is more than 10 milligram per deciliter. Okay, then if you get more than 3 of these, or 3 of these in the patient with COPD, you want to consider managing the patient in the hospital or in the ER. Let me say it again. We use the room criteria. Dyspnea score more than 5, respiratory rate more than or equal to 24, heart rate more than or equal to 95, SpO2 less than or equal to 92% on baseline oxygen, and C-reactive protein more than or equal to 10 milligram per deciliter. Okay, good. So always start with your short-acting beta agonists. And for example, albuterol or salbutamol, or you can use your levoalbuterol. Okay, just consider these. Don't worry so much about it. First line, you can use it in a nebulizer if the metered dose inhaler is not working properly. So I put it there. Do not be tricked. Are you going to use metered dose inhaler or nebulizer? Both work equally well if used correctly. Okay, so your first line is short-acting beta agonist, salbutamol, albuterol. Okay, now you can add a short-acting muscarinic agonist. And today I'm going to give you some exam tricks. The first exam trick I gave you is this point. This one, the one I'm highlighting, that both work equally good. Metered dose inhaler and nebulizer. The next one I'm going to give you is short-acting muscarinic agonist. You have to know something about that. For example, ipratropium bromide. So you can add ipratropium bromide to salbutamol or ipratropium bromide to albuterol. You can add it, right? However, you want to be careful if the patient is already on a long-acting muscarinic agonist like tiotropium. And one thing you need to remember for your MCQ1 exam is this. Which patients should you avoid short-acting muscarinic agonists in? You've got to avoid it in patients with urine retention or benign prostatic hyperplasia. Please, I need you to write this in your book. Which patients should you avoid, your muscarinic antagonist in? Patients with urine retention or benign prostatic hyperplasia. Because don't forget the muscarinic effects, right? It can cause the patient's urine retention to even get worse. So that's the example I'm giving you right there. Next one, continue long-acting inhalers. So somebody comes to you with COPD exacerbation. Most of the time, these patients are already on puffers, right? In the ER, if it is time for them to take their puffer, allow them to take it, right? Allow them to take it. Don't stop maintenance inhalers during exacerbation. Just add the short-acting beta agonist and the short-acting muscarinic agonist on top of that. But don't stop the maintenance inhalers the patients are taking. Okay. Now, when are you going to use your glucocorticoids? Number one, if the patient meets the Rome criteria, and we learned the Rome criteria, the 5 things which are in the Rome criteria, we learned that if the patient's symptoms are equal to or more than 3 of the 5 things in the Rome criteria, then you can give your steroids. Okay, and if the patient is also not improving with the bronchodilators you gave, give your steroids. What is the exam trick here? What's the exam trick here? When are you going to use inhaled steroids instead of oral steroids? Number one, if the patient has uncontrolled diabetes, try inhaled steroids. Why? Because systemic steroids can put the patient's glucose out of whack. If you've monitored patients with diabetes who are also giving steroids, you realize that their glucose control goes out of control during the time they are taking the steroid, right? So if the patient has uncontrolled diabetes, then instead of giving systemic steroids, you want to give oral steroids. You want to give inhaled steroids. Number two, if the patient has psychosis, then you want to try your inhaled steroids. Number three, if the patient has steroid sensitivity. So please, when you are reading your question stems, be very careful. What is it trying to tell me? Does the patient have uncontrolled diabetes? Then I want to hold on with oral systemic steroids and rather give inhaled steroids. Does the patient have psychosis? Because when patients take steroids, at times it can make them a bit hyper, right? And then if they have any steroid sensitivity, then you want to be very careful about that. When am I going to give antibiotics? Remember, it's a board exam. And if it's a board exam, you must have specific knowledge, right? If the patient has more than or equal to 2 of these. Number 1, increase dyspnea. Number 2, increase sputum volume. Number 3, increase sputum purulence. These are the indications for antibiotics. But if there are sputum changes but only one other symptom, then you want to depend on a clinical judgment, right? But for board exam, remember we did some questions on indications for antibiotics in the patient with COPD, increased dyspnea, increased sputum volume, increased sputum purulence. Then you want to give your antibiotics. Other things, remember we said that viral and bacterial respiratory tract infections are the commonest causes of COPD exacerbation. Therefore, if you have a patient with COPD exacerbation who comes to you in the ER, who meets you in the board exam, make sure that if there's the opportunity for you to test for influenza and COVID, you do it. And if the patient has symptoms of influenza, you treat the patient with your antiviral therapy, which is oseltamivir. So, as part of your workup for patients with, COPD, make sure that you test for your influenza. Make sure that you test for COVID-19. If they have the influenza, make sure you give your oseltamivir. If they have the COVID-19, make sure that you treat the patient appropriately. So you see, doctors, it's not just, oh, I've learned COPD. No, there are some things, specific things. Muscarinic agonists, indications. When am I going to hold on? Steroids, indications. When am I going to give systemic steroids? When am I going to give inhaled steroids? Right? What are the contraindications for short-acting muscarinic agonists? Okay? This is it. Doctor, so it's not just about, oh, COPD, exacerbation, increase sputum purulence, increase dyspnea, and then what am I going to do? No. QE1 is now specific, like MCQs, right? So you need to know, if I'm tricked this way, where am I going to go? If I'm taken this way, where am I going to go? Okay? Where am I going to go? So, you've got to also tell them that if they are going home, what are they supposed to monitor? Number 1, if their breathlessness is worsening, they should come back to the ER. If they develop any chest pain, they should come back, because remember that there was a question which we did, that which of the following is not a cardinal symptom of COPD exacerbation, and we realized that chest pain is not one of them. So you have a patient with COPD who has started developing chest pain. Please make sure that you tell the patient that if you develop any chest pain, you come back. The patient starts developing hemoptysis, something bad is happening. Okay, if the patient starts developing cyanosis, confusion or drowsiness, fever or chills, trouble with their daily tasks, they should come to the ER. So you have to know indications for reporting back to the hospital in a patient with COPD. And then, before they go home, you also want to make sure that you tell them to quit smoking, so smoking cessation, ensure medication adherence, and teach them how to use the medications properly, because we learned today that, metered dose inhalers work similarly to nebulizers if the metered dose inhalers are used well. Okay, so consider nutritional advice, home oxygen if needed, and clarify goals of care in frail patients as well. Okay, good. So what's the outpatient management of COPD? Summary points: bronchodilators, antibiotics if they have 2 cardinal signs, glucocorticoids if there's moderate severity, supportive care, encouraging smoking cessation and proper nutrition. You want to do your test for viruses, especially COVID and influenza. You want to avoid overuse of anticholinergics. Why? Because of the risk of urine retention. Continue their maintenance inhalers, education, okay, and dyspnea. And why should they come back? If there's worsening dyspnea, if there's worsening oxygen saturation, you want to deal with all these things. Doctors, please, has the class been helpful so far? Has the class been helpful so far? Has it been helpful? I'm just asking. Hello, doctors, please. Has it been helpful so far? Because we are going to go to another part, right? So the short-acting muscarinic agonist and the long-acting muscarinic agonist, like so hypertropium and tiotropium. Yeah, I think someone was asking that, doc, please, is it muscarinic and agonist or antagonist? The answer is antagonist, right? Okay. All right. So let's continue the class. So if it's been helpful, then let's continue. We are not done yet, so please. We are not done yet. Okay. So great tip for outpatient COPD management. If the patient is breathing better, has home support, and no red flags, you can treat them safely as an outpatient. Okay, that is it. If the patient is breathing better, has good home support, and no red flags, they can be treated as an outpatient. So let's go back to the hospital management of patients with COPD. Hospital management of patients with COPD. So we have a 74-year-old man with severe COPD presents to the emergency department with dyspnea and wheezing. He's using accessory muscles and has SpO2 of 90% on 35% Venturi mask. ABG shows pH of 7.38. PaCO2 is 58 millimeters of mercury. He started on inhaled albuterol and hypertropium every 2 hours after 6 doses in the first 12 hours. His breathing improves. What's the most appropriate next step? A, continue hypertropium every 2 hours for the next 24 hours. B, switch to albuterol alone every 2 hours. C, add long-acting beta agonist now. D, reduce hypertropium frequency and resume maintenance LAMA-LABA. And then E, discontinue bronchodilators and monitor only. Let's solve this question, and after that, I'll deal with this question from Dr. Zeddy. Let's answer this question. And after that, Dr. Zeddy has a question. I'll deal with it. So while we answer this question, Dr. Zeddy is asking, what can you educate them on? Smoking cessation and other causes? Yeah, so doc, you can talk to them about smoking cessation. You can talk to them about red flags and indications for return to the emergency room. You can talk to them about nutritional support. You can even talk to them about pulmonary rehabilitation, right? You can talk to them about all these things. Okay, so what's the correct answer for this patient? I see a lot of people going for B, others are going for D. So you want to reduce hypertropium frequency and resume maintenance LAMA and LABA. Remember that we give hypertropium and our SABA, which is short-acting beta agonist like Ventolin, albuterol, in the acute exacerbation. And remember, we also said that you continue your long-acting treatment, right? Now, if the patient comes out of the COPD exacerbation, they just have to continue their long-acting LAMA and LABA. Their tiotropium bromide and all those things, right? Okay. Now, a 70-year-old woman with a history of hypercapnic respiratory failure is admitted with a COPD exacerbation. She is drowsy and her SpO2 is 87% on room air. Arterial blood gas shows pH 7.28, PaCO2 65. PaO2 is 55 millimeters of mercury. What's the most appropriate initial oxygen target? So with all the big English and the words, the question is, if you have a patient with COPD, what's your target for oxygen saturation? A, is it 95% to 98%? B, is it 90 to 94%? C, is it 88 to 92%? D, is it SpO2 of 100% with non-rebreather mask? Or E, is it FiO2 more than or equal to 50% with goal PaO2 of more than 80 millimeters of mercury? What's the target for COPD management so far as their oxygen is concerned? And the correct answer is C, is 88 to 92% on like 82 to 92%. So if you can get them to not like patients who are not needing oxygen and the oxygen saturation comes between 88 to 92%, great, you're good to go. Okay, so far as the patient doesn't have any other clinical comorbidities and is stable to go home, you've achieved the oxygen saturation now. Okay, next one. A 65-year-old male is admitted to the hospital for a moderate COPD exacerbation. He is able to take oral medications and has no evidence of shock. What's the most appropriate glucocorticoid regimen? This question, I think it's a bit over the top for QE1, but I will still bring it. So methylprednisone 125 milligram IV every 6 hours for 5 days. Prednisone 40 milligrams orally once daily for 5 days. This is more for TDM candidates. Okay, this one in particular. So if you are preparing for a therapeutic decision making, this some like I would have taught you this as well. Hydrocortisone 100 milligrams IV every 8 hours for 7 days. No glucocorticoids needed if bronchodilators are working, and budesonide for mitral high dose inhaler alone. What's the correct answer? But if you can still deal with it, that would be awesome. Okay, it's a bit over the top for the scope of MCQ1. MCQ1, you don't need to really worry about medication doses apart from something like epinephrine in the case of anaphylaxis, right? Apart from that, you don't need to really worry yourself so much about medication doses and frequencies and the rest. Okay, but I see a lot of doctors going for B. So someone is asking, so that's why I said, can patients be at 88 to 92% and still feel discomfort? In this case, what can be done? So in the simple situation, Dr. Richard Kwame Asari, in the simple situation, that's our target and would have discharged them. But I'm just saying that you may have that patient and the patient may have other comorbidities, right? So even though you're not giving more oxygen, you may be giving other treatments to that particular patient. But if all things are good, the patient doesn't have any other thing apart from the COPD, then you can discharge the patient. Okay. So the correct answer is B, right? Prednisone 40 milligrams orally. And we have to remember what we learned. Indications for inhaled steroids alone, and when we want to avoid oral steroids, like poorly controlled diabetes, right? We learned that, like psychosis, like sensitivity to steroids, right? Okay, good. So B is correct, and it reflects the gold and guideline supported management of patients with COPD exacerbation. You realize that A is asking that we give IV methylprednisone. That's a bit over the top, right? Okay, good. So treat the flare-up, avoid intubation, stabilize with oxygen, and support the patient. That's what we want to usually do if the patient comes in and wants to send a patient home. Okay, so you want to reverse the airflow obstruction. That's why we give your short-acting beta agonist and your short-acting muscarinic antagonist. Short-acting beta agonist and then short-acting muscarinic antagonist. That's when you give your Ventolin, and then you can give your ipratropium bromide. And then you want to reduce the inflammation with your systemic glucocorticoids, right? And then you want to treat infection if it is suspected with your antibiotics. And you want to provide your oxygen, but you want to provide it carefully. Keep the oxygen saturation between 88 to 92%. And if possible, you want to do everything possible to avoid ICU mechanical ventilation. Okay? All right. So I just put this one here. You don't need to really worry so much about it, but I just put it here for academic purposes. So no respiratory failure. These are the things you want to look out for. Respiratory rate is less than 24 cycles per minute. Heart rate is less than 95%. Heart rate is less than 95 beats per minute. SpO2 is between 88 to 92% on 24 to 35% FiO2. The patient does not have any hypercapnia. Okay? Now, jump the middle one and go to the life-threatening. Life-threatening COPD, if the respiratory rate is more than 24 cycles per minute, the patient is confused. If the patient needs more than 40% FiO2, if the patient's PaCO2 is more than 60, or pH is less than 7.25. In other words, this patient is acidotic. Then it's life-threatening. Okay? Good. Just wanted to put this out there. So Bronchodilators, remember again, SABA, SAMA, short-acting beta agonist, short-acting muscarinic antagonist. Okay, the preferred one we use is nebulized hypertropium albuterol. Remember, you want to be careful with short-acting muscarinic antagonist in patients with benign prostatic hyperplasia and urine retention. Okay, use an air-driven nebulizer to avoid worsening CO2 retention, and avoid SABA alone unless the patient cannot tolerate the SAMA. So SABA is avoid Ventolin alone. Make sure that when you're giving the Ventolin, you are giving it with some hypertropium bromide. Okay, good. Oxygen therapy, you want to titrate it carefully. We've already dealt with it, but you want to keep the SpO2, the oxygen saturation, between 88 to 92%, and then the PaO2 should be between 60 to 70 millimeters of mercury. In the exam, the trick is that if you over-oxygenate the patient, there's a risk of carbon dioxide retention, and there's a risk of acidosis. So you want to be very careful with that. So, systemic steroids. Who to use systemic steroids in hospitalized patients? Hospitalized patients. Almost all hospitalized patients should be given steroids. Okay? And you give IV if there is severe exacerbation and the patient cannot tolerate oral steroids, or if the patient is in shock. Otherwise, oral steroid is effective. Okay? And why do we give steroids if there's treatment failure? We give steroids to reduce treatment failure, to reduce hospital stay. But then remember that when you give steroids, it can cause increased glucose levels, so hyperglycemia. That's why I put it here. Okay, so if you are giving steroids, you want to monitor the patient's glucose. Exam trick: if the patient has been on steroids for less than 2 to 3 weeks, there's no need to taper it. If the patient has been on steroids for just less than 2 to 3 weeks, there's no need to taper it. You taper steroids if the patient has been on steroids for a longer period. Okay, good. What about antibiotics in hospitalized patients? Almost all patients with hospital admission for COPD will need antibiotics. Okay, so don't delay antibiotics if infection is suspected. All right, good. And remember to test your patients for influenza and COVID-19. And if they test positive for influenza, give your oseltamivir. All right, awesome. And then, when can you resume long-acting inhalers in hospitalized patients? When you are giving your acute SABA-SAMA, you want to hold it, because we said that you don't want to give your tiotropium bromide and then add on your hypertropium bromide. That can cause a problem. Okay, but as soon as the patient improves on the short-acting muscarinic antagonist, you can go back to the long-acting ones. And that is a good time to also teach the patient about inhaler techniques as well. Okay, and if the patient is in the hospital, you want to encourage smoking cessation. You want to give NRT, is nicotine replacement therapy. Okay, you want to give your DVT prophylaxis if necessary. You want to monitor fluid balance because of the issue of congestive heart failure, and you want to provide nutrition support as well to the patient who is in the hospital. So, what are the quick facts you need to remember about COPD in the ER? Number one, you have to know the features of impending respiratory arrest. What are the features? If you are going to a QE1 exam, you need to know inability to maintain respiratory effort. That means the patient is in impending respiratory arrest. If there's cyanosis, that means the patient is in impending respiratory arrest. If there's hemodynamic instability, that means the patient is in impending respiratory arrest. And the patient has depressed mental status, that means the patient is in impending respiratory arrest, right? Now, we said that COPD can lead to other complications. For example, cor pulmonale. So how do you pick up cor pulmonale in the MCQ1 exam? If there's jugular venous distension, that's number one. If there's prominent left parasternal heave, that's number two. If there's peripheral edema, that's number three. You don't want to miss any of these, right? And then diagnostic testing for a patient with COPD in the hospital. Do not be tricked in the board exam. I'm saying this again. When you see this guy with a light here in your exam preparation and MedCognito is talking about it, that means these are things you need to remember. If the patient is in the ER, how do you check their oxygen saturation? Use continuous pulse oximetry. Okay? If you have a patient with COPD exacerbation, make sure that you check their arterial blood gas, ABG, sorry. Do not assess for peak expiratory flow or spirometry in acute severe COPD. There's no need, because the results can be inaccurate. Okay? You wait. If they come out of the exacerbation, then you can refer them for respirology or for a respiratory therapist to test that for you. And in a patient with chest, like with COPD exacerbation, make sure that you obtain your portable chest radiograph and look for other things like pneumonia, heart failure, and pneumothorax, because these can be critical differentials that you don't want to miss. All right? Now, when evidence of acute infection is absent and the chest radiograph is not revealing anything, remember you did your chest x-ray. If the patient is still showing signs and symptoms of things you're not sure about, get your CT pulmonary angiogram, because we said that one differential you don't want to miss in a patient with acute COPD exacerbation is pulmonary embolism. Get your blood work, complete blood count, electrolytes, BUN, creatinine. Also get your cardiac troponin, because we said one of the differentials is myocardial infarction. Get your BNP, brain natriuretic peptide. Why? Because one of the differentials can also be heart failure. And you do all these things if the diagnosis is not certain, right? Don't forget to test for your influenza. Don't forget to test for COVID-19. Get your ECG, especially if the patient has an arrhythmia. And don't forget that an arrhythmia can also be a differential of COPD exacerbation. So, who do we admit to the ICU? Doctors, am I giving too much? Are we giving too much stuff today? Are you tired? Let me know. Are you tired? Are you tired? So someone says, Dr. Boni, someone just texted me on WhatsApp. Says, Dr. Boni, so you are giving all this in a free lesson. How much more? What is happening in the actual paid class? I was like, yeah. Okay. So someone says, no, you're not tired. So let's continue. Okay. So ICU admission criteria for hospitalized patient with COPD. The patient has high risk comorbidities, pneumonia, cardiac arrhythmias, heart failure, diabetes, renal failure, liver failure, you want to admit. Continued need for non-invasive ventilation or invasive ventilation, you want to admit, right? Hemodynamic instability, you want to admit. Need for frequent nebulizer treatment, you want to admit to the ICU. Okay? All right. And then one more tip before we do our recall. One more tip before we do the recall. One thing you don't want to miss: if you have patients who present with respiratory failure or severe exacerbation that is not responding promptly to short-acting inhaled bronchodilators, one medication you don't want to miss is magnesium sulfate. So you've given your Ventolin, you've given your hypertropium bromide, you've given your oxygen, the patient is still needing help for your board exam. Don't forget this medication, magnesium sulfate. It also has bronchodilator effects. Magnesium sulfate, it also has bronchodilator effects. Okay, so please, with all that we've learned so far, who is ready for the active recall? Who is ready? We are going to do active recall of everything we've just studied. Okay, so please make sure you get your keyboards, because it will be quick. I ask the question, you need to type the answer. I ask the question, you need to type the answer. Please, if you are ready, let's go. But before that, remember that MedCognito runs a tutoring program for doctors preparing for the MCQA1. Okay, remember that. And in your portal, you will have everything. So, for example, COPD exacerbation may be in either respirology or emergency medicine. Okay, it may be in respirology or emergency medicine, and you have all the rest on your laptop as well. And so it helps you to know how to prepare for it. Tonight, those in the program, you have a class. So if you want to also join us to join that class, please don't forget. Just have to get registered and we go. What does it take when you're in the program? You're going to get line upon line review of everything. So like what we are doing, you're going to get it. Okay? You're going to get it. You're going to get 14 live classes every month. 14 live classes every month. You also have mock exams in your portal, in your study portal itself. And then every 2 weeks, we conduct a mock exam as well. And you will get a personalized interactive study portal. Okay? You get a personalized interactive study portal. Okay? Take it. No, take this. Bye-bye. Sorry, my daughter just came here. I don't want to take this. Then let me finish. Let me finish teaching. Then we go. Okay?
Can we go to Spark Center?
Sure. You go upstairs. After that, we go to Spark Center. Okay? Sure. Okay. So personalized interactive study portal as well. All right. So they are little MedCognitos. They are just learning what we are doing here. So they came in to help. Okay. Okay. Good. So you get all these things in your study portal. You also come in, like we have teachers who are practicing physicians who will also come in to help, including myself. We do med drills as well. Okay. And you get all these things for just 2,199 for 6 months access. But somebody may say, Dr. Boni, no, I don't want to just do 6 months. My exam is in 3 months. We have a package for that. All you need to do is just reach out to me. Reach out to me at +1 306 891 5649 and we'll get you going. Okay? Right after this class, just reach out. We'll get you into the class. Okay? And then for those who are also preparing for the NAC OSCE, we're currently running a promo. It will end on the last day of May. From June 1st, it will go to 1,997. Currently, it's at only 1,499. All right? So self-paced models you learn on your own before you come to class. When you come to class, the teachers will also take you through some hardcore stuff. Okay? So that is it. If you need that as well, reach out and I'll guide you through it. So if you also want to reach out to me, my phone number is +1 306 891 5649. +1 306 891 5649. We are here to help you. So doctors, let's go back to recall. Now this one, 30 seconds and we go. Okay? Now, what are the 3 cardinal symptoms of COPD exacerbation? Please type in your answer. Type in your answer. Type in your answer. What are the 3 cardinal symptoms of COPD exacerbation? Quick. So this doctor says what? You are very generous to give all this information in your free session. Yeah, doc. Well, what do we lose? We lose nothing by doing what we do, right? We lose nothing. We'll spend hours to prepare so that we can give you quality information. Okay? This is a free session and we spent almost 2 hours already. I'm blessed. I'm happy about it. Why? Because we are happy helping other people. Okay? Someone also says this. Dr. Boni, can magnesium sulfate in COPD treatment, COPD treatment later lead to respiratory depression? Is this key on question? No. Like, yeah, if you have a patient who is not responding to, all the inhalers and everything, last but not the least, you can give magnesium sulfate, okay? And remember that magnesium sulfate can also be given in asthma management as well, okay? All right, sure. So what are the 3 cardinal symptoms? Let's go. Oh, someone says I should put my contact again. +1 306 891 5649. +1 306 891 5649. Or you can see the bottom of the screen, it's rolling there, okay? But let's go back to the recall questions. So 3 cardinal symptoms of COPD exacerbation: increased dyspnea, increased cough, and it can be frequency and severity. Number 3, increased sputum production. It could be volume or purulence, okay? So increased dyspnea, increased cough frequency, increased cough severity, increased sputum volume, and increased sputum purulence. Next one. What are the 5 Rome criteria used to classify moderate outpatient COPD exacerbation? I want to know. What are the 5 Rome criteria used to classify moderate outpatient COPD exacerbation? Please type it in the comment section. Type it in the comment section. Active recall. Because a lot of candidates contact me, Dr. Bonnie, I want to learn how to study. I want to learn how to study. What I've realized is that many of us did not learn how to study in medical school, right? We learn passively, and then when we come to Canada as well, because of work and everything, right, it becomes tough. So yeah. So what are the 5 Rome criteria? 5 Rome criteria. 5 Rome criteria for COPD exacerbation. Number 1, dyspnea score more than 5/10. Number 2, respiratory rate more than 24 cycles per minute. Okay. Number 3, heart rate more than 95 beats per minute. Number 4, SpO2 less than 92% on usual oxygen. And then number 5, CRP more than 10. So these are the 5 components of the Rome criteria for moderate outpatient COPD exacerbation. Okay. Next question. What's the target oxygen saturation range in COPD exacerbations? What's the target oxygen saturation range in COPD exacerbations? Please type your answer. What's the target oxygen range? Good. Dr. Sarah, beautiful, beautiful, beautiful. Dr. Sarah, beautiful. 88 to 92%. Okay, good. What ABG findings suggest life-threatening respiratory failure? What arterial blood gas features suggest life-threatening respiratory failure? What arterial blood gas features suggest life-threatening respiratory failure? Someone says acidosis, sure, but what is it? What value? pH less than 7.25. Okay, pH less than 7.25 and PaCO2 more than 60 millimeters of mercury. These are the things which suggest life-threatening respiratory failure. Okay, so doctors, you can see on the screen that your comments are also showing live, right? Beautiful, beautiful, beautiful. So the PaCO2, Dr. Farrakhan, is more than 60. Okay, more than 60. Okay, what signs should make you consider hospital admission in a COPD exacerbation? Because if you're able to recall, then it means that the learning we did is solidified, right? What signs should make you consider hospital admission in a COPD exacerbation? What signs should make you consider hospital admission in a COPD exacerbation? Do you remember that? Number 1, severe dyspnea. Number 2, altered mental status. Number 3, use of accessory muscles for respiration. Number 4, failed to respond to outpatient therapy. Okay. Number 5, lack of home support. Number 6, serious comorbidities like arrhythmias, right? Pneumonia. Okay. Now, which bronchodilator is first line in all COPD exacerbations? Remember, MCQ1, level of medical student knowledge. So you need to know common things, right? So which bronchodilator is the first line in all COPD exacerbations? Which bronchodilator is first line? Which bronchodilator is first line? Who can help me? Beautiful. Inhaled short-acting beta agonist, SABA, or albuterol, or someone will say salbutamol. Okay, Ventolin. Okay, when are antibiotics indicated in outpatient COPD exacerbation? Please tell me. Q1 made ridiculously simple. When are antibiotics indicated? When are antibiotics indicated? When are antibiotics indicated? Who can help me? Who can help me? Who can help me? When are antibiotics indicated? We talked about it. We talked about it. We talked about it. Doctors, we did talk about this. We talked about it. When are antibiotics indicated? When are antibiotics indicated? Who can help me? Who can help me? Who can help me? Who can help me? The correct answer is when the patient has more than or equal to 2 of the cardinal symptoms, especially if there's sputum prolens is one of them. Sputum amount, right? And the cough is worsening. Okay. Name 2 conditions in which inhaled corticosteroids may be preferred over systemic corticosteroids. Name 2 conditions in which inhaled steroids are preferred over systemic steroids for your MCQ1. Name 2 conditions in which inhaled steroids are preferred over systemic steroids. Well, it's not just diabetes. It's not just plain diabetes. We said it is uncontrolled diabetes. We also said if the patient has psychosis or steroid intolerance. Okay, so uncontrolled diabetes, psychosis, and steroid intolerance. Okay, good. So what combination of drugs is preferred for bronchodilation in hospitalized patients? What combination of drugs is preferred for bronchodilation in hospitalized patients? What combination of drugs is preferred for bronchodilation in hospitalized patients? And the correct answer is short-acting beta agonist and short-acting muscarinic agonist, right? Nebulized albuterol and hypertropium bromide. Beautiful. When should IV steroids be used instead of oral steroids? When should IV steroids be used instead of oral steroids? When should IV steroids be used instead of oral steroids? When should IV steroids be used instead of oral steroids? Who remembers? When should IV steroids be used? Oh, remember that we talked about using IV steroids in the ICU, right? And we talked about patients who are severely ill, patients who are vomiting, patients who are in shock, right? Patients who are unable to absorb orally. Okay. Now, which antiviral is preferred in hospitalized COPD patients with influenza? Which antiviral is preferred? Which antiviral is preferred, please? Who knows? Which antiviral is preferred? We've talked about all these in the class. Which antiviral is preferred? Which antiviral is preferred? Doctors, let me know. Let me know. Which antiviral is preferred? Someone says Ocel. Yeah. So it's oseltamivir, 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 oseltamivir. Okay, good. When should long-acting bronchodilators be restarted during hospitalization? When should long-acting bronchodilators be restarted during hospitalization? And the correct answer is once the symptoms improve and the patient can use an inhaled corticosteroid properly, then the long-acting bronchodilator should be restarted. Okay? Now, what are the contraindications to using non-invasive ventilation? What are the contraindications to using non-invasive ventilation? What are the contraindications to using non-invasive ventilation? Do you remember? What are the contraindications to using non-invasive ventilation? We talked about it in the class. Number 1, altered mental status. Number 2, inability to protect the airway. Number 3, excessive secretions. Number 4, facial trauma or vomiting. Number 5, we talked about that. So, what supportive interventions should be considered in all admitted COPD patients? What supportive interventions should be considered in all COPD admitted patients? What supportive interventions should be considered in all admitted COPD patients? What supportive interventions? We talked about it in class. We talked about it in class. What supportive interventions? What supportive interventions? Remember, you talk about smoking cessation. Remember, you talk about nutritional support if they are undernourished, right? Remember, you talk about monitoring for fluid balance. So that is that, doctors. So how was the class today? Hope the class was helpful. Hope the time you spent with us was good. 2 hours of intensive learning so far as COPD is concerned. 2 hours of intensive studies. I've really enjoyed today. Okay, that is what MedCognito is here for you. So please don't hesitate to reach out. My phone number is what I'll show on the screen. Okay, reach out. Usually I prefer WhatsApp so that we can, wherever you are in the world, we can get to you. Okay, reach out. Just reach out, doctors. We are here to support you. +1 306 891 5649. Remember, NAC OSCE is starting on June 3rd. QE1 will continue tonight. So those in the Q1 class, get some rest and then join the class again. This doctor says, I like MedCognito. Sure, doctor, I also like MedCognito. Dr. Saha says, really thank you. Dr. Mew says, fantastic. Dr. Dogua says, excellent, Dr. Bruni. Thanks a lot, Dr. Bruni. Wonderful. Dr. Sabine says that. Doctors, we live for this. We want to make sure that we get. Last time I was talking to somebody who was saying that, what is one news item that you will hear that you know you've contributed to, but maybe you are not giving any credit for it? And I was like, if I hear it on the CBC that, you know, over the period, they've noted that the wait times in hospitals and clinics have reduced because we are getting more doctors, you know, licensed. And I know very well that we are getting a lot of doctors into the residency program. I'll be very glad. You know, we want to impact the Canadian healthcare system. And we know that, you know, we have so many doctors who are very qualified, who were not trained in Canada. And that is why we want to do this. Okay? If I hear that news, I'll be very glad that, you know, in BC, in Alberta, in Saskatchewan, in Ontario, you know, the wait times have reduced. Why? Because more doctors are helping. We have gotten more doctors in the system. I will know that we've played our part as MedCognito. So doctors, that's what we live for. So please reach out to me. And if you reach out, I will respond to my own phone. Okay, +1 306 891 5649. Doctors, if you also reach out and maybe I don't respond directly, maybe I may be seeing a patient or, you know, dealing with the little MedCognitos who came here. So I will definitely get in touch. I will definitely get in touch. So reach out right away by WhatsApp. Let's get the ball rolling. Thank you very much for spending your day with us. We really, really, really appreciate it. God bless you and stay safe. Bye-bye. Bye-bye.